I'm Dr. Gemma Jones, and I'm going to explain a little bit about dementia in this film. In essence, the word dementia doesn't have a fixed, accurate meaning. It covers so many things. So dementia is a syndrome word, or like an umbrella word, and it's going to refer to 100 or more different types of illnesses. And the thing they have in common is that they're going to cause difficulty to some aspect of memory, functioning, and other aspects of our thinking ability. So that might be the ability to pay attention, to think logically, to problem solve, to learn new information, to order and sequence information, to calculate, to understand how to put pictures together of what's going on in your environment, to make visual maps, and to have a sense of where you are in space, and to be able to link information accurately to what's going on around you, the context and the emotional atmosphere of what's going on around. So different dementias, depending on where they start and where they spread to in the brain, will affect different types of functioning. The common thing to everything in the definition of dementia is that someone will have difficulty with their memory and some other aspect of functioning, and that's serious enough to interfere with work or social relationships. Dementia is not losing your memory, because memory isn't an all or none thing. It's not one thing that either you have or you don't have. Dementia is not losing your mind, because we don't know what mind is. It's a complex blend of many things. And too often it's just associated with brain, which it isn't. Mind isn't just brain. And so we have to leave those old concepts behind. And neither is it losing your personality, which so many people thought was inherent in it, because it used to be part of the old definitions. So we don't really know how to define personality well, because it's a blend of your hereditary and experienced factors in life too. The tendency now is to say whoever you are, that's who you take into your dementia with you in most types of dementia. And you become, as it were, not diluted, but a caricature of yourself. That would be a more accurate way to describe most people who have dementia. We don't know yet how many types of dementing illness there are. We know in the literature that it's agreed there are more than 100 types of dementia. Some people have already written articles suggesting there are more than 200 types. So you see how vague and difficult that gets. We know a little bit about dementing illnesses in the field of dementia, but we're just at the beginning of being able to know more, because so little is really known about the brain in any absolute sense. We can't refer to memory ability anymore as just one ability. So we're going to talk about different types of memory. And when I teach about it, because it's so complicated a subject and there's so many types of memory, I like to talk about memory for facts, memory for the emotional flavor of things, and I like to talk about memory within each sensory ability, and I'm going to lump those together as sensory memory. So I'll talk about 3 types of memory ability. And in most types of dementing illness, the frequently occurring ones, we see that people will have difficulty with memory for facts, but not so much with memory for the emotional flavor of things, or with sensory memory necessarily. So the goal of teaching people how to understand the illness and what it's like to have dementia is to try to get people increasingly to think about the possibility that there comes a point where people may be completely wrong with the facts they're telling you, because the detail, the accuracy is gone or can't be related accurately. But the feeling of what people are telling us, the emotional flavor, can be 100% correct. And our difficulty then is learning how to speak with an adult who isn't telling you correct facts, and we don't have the skills yet to know how to congratulate people for doing their very best with the way their brain works, to describe their world to us in emotional flavors and emotional tones. If you take a dementing illness which can last over 22 years, we need some handles on working how to divide an illness up. So if we take an Alzheimer type illness and say, well, let's divide the illness up into 4 stages or phases, just so we have some anchor points as to where in the dementia process a person is, otherwise we get lost, then we can speak about teaching people how to speak and understand 4 different languages, because language ability is going to change from stage to stage to stage. And the types of fears that people will experience will change from stage to stage to stage, depending on what they can comprehend and what they can perceive through their senses. And then we say their ability to stay connected to people and to things changes from stage to stage. And their language functioning, very specifically in terms of what they can generate, is going to change. So once we have a framework, then we have like a shorthand for talking about the difficulties that people have and the preserved abilities they have. And we can talk about goals of care in a kind of a shorthand way, because otherwise there's so many things that will change. It's very, very hard to be accurate about what's happening to someone in plain English. Sometimes diagnosis is done very quickly if people have one of the commonly occurring types of dementia. So if people have an uncomplicated type development of Alzheimer's disease, that's not so hard to spot. If people have some small strokes and they're progressive, there's a way you can fit that pattern together. And if the strokes are located in areas that help us to think, in the cognitive areas of the brain, we call those the hippocampal areas, that's pretty easy to put together. Some of the illnesses that are more difficult are just ones that we can't scan yet properly. We can't see evidence of on scans early on in the illness, and we can't do routine blood testing for it. And there are so many things that can go wrong with people that will change either their behavior or their ability to think intermittently, or their ability to recover from changes in their mood, that it's very easy to mix that stuff up. If people are very young when they have difficulties, it's very easy to write it off as someone who's having a bad response to stresses in life, or they're not adapting well to retirement, or in the case of women that they're having trouble with menopause. So all those things can delay an accurate diagnosis. And we've seen people at the Alzheimer cafes who've gone through 4 rounds of diagnosing. It's taken sometimes 7 years to get a more accurate diagnosis. So sometimes if it's straightforward, it should be easy to diagnose. Sometimes when people have rare types of dementia or multiple types of dementia on top of other illnesses or injuries, it can become very, very complicated to work out what's happening.
Talk to me about the difference between a possible and a probable diagnosis.
Okay, so ultimately, until you've seen proof in the brain about what type of damage is happening there, you can't be sure what type of dementia a person has. So if you know someone's had a big stroke and you can see the damage from the stroke on a scan, that's easy. If someone has a brain tumor in areas of the brain that are affecting the thinking parts of our abilities, then you can figure out what's going on there. But for many of the other types of dementia, we can't see what's what until you look at the tissue microscopically, which we can't do in a living person usually. So if the pattern appears to be simple and it fits in a known pattern, then we say, okay, it's a possible diagnosis of, say, Alzheimer's disease. And with a good memory clinic workup, those diagnoses are usually 90 to 95% accurate, according to the research papers that looked into accuracy of diagnoses already 20 years ago. However, if someone has a lot of other illness before they have any difficulty with thinking abilities, so they might have thyroid troubles, or they might be diabetic, or they might have undergone a lot of recent losses or trauma, they may be on medication that doesn't agree with them, and having a lot of other life changes. They may have fractured a hip or a knee, or had to move and not be adjusting well to the neighborhood because they don't have normal supports in place. And then on top of that, they start to show some changes in their thinking abilities. Nobody knows whether or not that's as a consequence of what was already there and the changes, or whether or not it's a real new dementing illness starting out. So in that instance, when it's not possible to get a handle on a simple presentation, we say it's a possible diagnosis of dementia. So the diagnosing isn't 100% accurate. It's the best guess that we can do depending on whether or not the person has been diagnosed well by what kind of memory clinic team, and how much information those professionals have about the person's baseline level of functioning, and their knowledge about what's changing. And it's very easy for people to hide information about what's changing in their life, because when they speak to someone who's a professional, they like to present themselves at their best. So we know, according to the estimates, that sometimes about 1 in 5 people who have some kind of a reversible cause for cognitive change, just a temporary thing, are being missed. And sometimes people who have real dementia are being missed because they're presenting well and hiding their difficulties. So the diagnosing is the best we can do, but it's not 100% accurate. We know from the Dementia 2010 report that 69% of people with dementia in the UK are thought to be unknown to their GPs. And that's probably 20% higher than we anticipated. And we're guessing that 1 in 5 people who have some kind of a reversible reason for cognitive decline are having that missed because people aren't knowing the full details about what's happening to them. I think in terms of what people hear rumors from and what they get from the press when difficult stories are investigated about the care people receive in care homes, is that people with dementia are aggressive. I would say that's the biggest misunderstanding of dementia. So people with dementia, just like anybody else, can become very angry and very frightened when they can't figure out what's going on accurately, and they mistake that to be a situation of threat. So the difference between fear and anger tends to be something catches you off guard, you can't work out what's going on, you're frightened. As soon as you find a target, or you think you found a target for what's put you in that position of compromise, then you become angry. You don't become angry till you've got a target. So those things are really, really tightly linked. And I think we need to explain to the public as a number one message that many of the behavior changes we see in people with dementia and the mood swings are a result of being startled throughout the day by situations that are not easy to interpret, and sometimes visually not easy to interpret, and sometimes conceptually not easy to interpret, especially if you're having little patches of memory difficulties throughout the day when it's intermittent in the early stages. So everybody, every human being, when they're frightened or angry, can behave unusually, and people with dementia do that too, but so often that's just blamed on the dementia, and it's often even referred to as a neuropsychiatric symptom of dementia, whereas we would say in normal adult language, when you're struggling with an illness you can't get better from and you try so hard and nothing you do is making a difference, no wonder you have these times when you're frightened or angry or sad, or just you want to be by yourself, but you don't want to be by yourself. You're conflicted. So it's almost like you say to people, leave me alone, leave me alone. But in your head, you're saying, please don't leave me alone. Please don't leave me alone. Please see through this facade that's I've got on, because I don't know what's going on and I can't control it. And I'm so frightened, and I'm adult. I've never had to ask for help before in my life. And sometimes my ego is getting in the way of asking for help. And so it takes a big jump to work through all that. And when your thinking isn't at its best, sometimes we see that people are struggling, and what the outside world just sees is a person who's out of control. They don't go back to the roots of the fear and the anger, just like happens with all human beings. Please, if you have any influence over the quality of the lighting, make sure that there's good ambient lighting in the rooms where you're working with people who have dementia. Because when you reduce darkness and shadows, you can help people to recognize faces more accurately longer. You can help people to be less hesitant in their walking because you reduce shadows on floors. You can help people to do activities longer that they need good lighting to do, like even writing or playing cards or games. So lighting is crucial to so many areas of care. Also recognizing who the people are around them in terms of newcomers, new staff, and who's wearing what. The second thing that I would like people to think about is the difference between different types of visual mistakes that people will make as they have particularly an Alzheimer type illness. So not everything that people don't see accurately is hallucination. Sometimes it's that people are just seeing in poor focus. And sometimes it's that people can't problem solve visual illusions. They're seeing a reflection of something and they can't work out that it's a reflection, so they think objects are where they're not, like reflections in windows and mirrors. Sometimes people misidentify patterns. And sometimes they don't have the words to describe what they're seeing. One lady had 4 new green pillows on the couch, and they had little ruffled edges, and she was very pleased with these new cushions. And a social worker came in to visit with her, and the lady said, "Go and look at my 4 new green cabbages there." And the social worker assumed she was hallucinating because there were no 4 green cabbages. So just when you can't find the right word, but the concept is still there's these green things with sort of little pretty edges on it, you have to understand how noun finding ability and other language difficulties change. So that would be a really important thing for me to know. And the last thing, in this very short interview would be, can you learn how to get at the story that a person has inside their head about what's going on around them in the world? And do you know that it's so unhelpful to ask why of a person who has dementia? So ask all the other good questions to get at the story. And what you're trying to do in that exercise is not say the story is right or the story is not right, or these facts are right or these facts aren't. You're listening to what the person's take is on what they're experiencing, and that will give you handles for care. And when you have the ability to look at a person, that you can register as quickly as possible what emotion they're probably experiencing in that moment, so you can validate their emotions accurately with accurate empathy as 2 of your most important communication interventions. That would be the message I would want to give to as many professionals as possible. That's a tricky one. I would ask families to please think about going to the Alzheimer Cafe near them as soon as possible, if there is one, or otherwise getting hold of some of these materials which will feature very pertinent information to what you need to know as soon as possible. This little book in particular about dementia for families with children. There's often been so much backdrop to changes in family relationships before a person gets diagnosed. And a lot of it's emotional distancing, because when someone doesn't know that there's dementia possibly happening, some type of dementia occurring, the person's motives are often attributed as being mean or thought out or deliberate. And people don't realize that there's a lot of trying to save face and not realizing and just short-circuiting of ability going on. Families often, and it's probably the most difficult message I have to give families during a family carers course, is do you really know the difference between someone who cannot do something and someone who cannot do something intermittently and someone who will not do something for you because you've asked? And many families will say, for example, I did all the work to do the barbecue for my wife. I was going to surprise her. I cleaned the deck chairs, I mowed the lawn, I got the barbecue ready, and all she had to do was make the salad, and she wouldn't make the salad. And then I try and say, well, could she make the salad? So what did you do? I said, did she do the groceries? No. Did she put the groceries away in the fridge? No. So did she know where they were? What did you do? Did you just tell her, make the salad, I'll do everything else? And in that instance, that's exactly what had happened. So when the husband finally came in, expecting to eat and expecting to see the salad in the bowl, he found a tomato in the bowl, a leaf of lettuce, a half an onion, and stuff spread all over the kitchen. So he hadn't realized yet that his wife could prepare a salad, but only if he helped her organizationally. What she couldn't do was make random trips around the kitchen, searching for things she hadn't put away and didn't know if they were there or not. She didn't know where the salad bowl was. She didn't know where the knives were anymore. So after she'd done this toing and froing, she got lost in that task. She was busy the entire time. She couldn't pull it together. So when he realized that had he put everything on a tray, the salad bowl, the cutting board, the knife, and all the vegetables that were to go in the salad, and had he seated her at a table and said, please work on this while I'm doing things outside, she could have produced a salad for him. And in the same way, when someone's having trouble dressing themselves, you don't expect they're going to have success by going to the cupboard and being able to find all their bits of clothing and match them. You lay out some clothes on the bed and maybe 2 or 3 choices, but you don't let someone just go to the cupboards and try and figure out what to do, because that's beyond their ability to organize at a certain point. So families do very well in adapting to that once they understand what the difficulties are. But traditionally, we've thought of dementia means having memory troubles. We didn't think about dementia in the normal sense, especially in an Alzheimer type illness, always is affected by other abilities simultaneously. The hardest part of the illness is understanding that in early stages, there is still such intermittency possible. So once people know that, they can work with it. But if they don't know, it just feels like someone's uncaring and deliberately uncooperative, and that it feels like the affection and the interest and the attention, the love is being lost, and that doesn't help care.